Well, we've got some new rules this year. Did everybody know that? So there is a new scoring manual, and there are some new rules associated with that scoring manual. And so today I'm really going to go through that. As was mentioned, I do work for Knox Medical, but that has absolutely no conflict with the information that I'll be presenting here today. So our objectives are going to be, oh, fantastic, that's great. New technical and digital specifications for some PSG reporting. We'll talk about those and what's required on your reports. We're going to talk about some new sleep staging and scoring rules and some of the tweaks to those. There are a couple of new arousal rules and then some new cardiac rules, and those are the ones I decided to keep my comments to. There are a few other things that are more clarifications, and so I really tried to stick to these changes because they're the true changes in the manual, and these are the things that are going to keep me from talking for 2 or 3 hours up here with all of the little details that they go through. So I thought about doing this as one of those little quiz things like Dr. Talent did last year, but I thought with the virtual plus here, it might just be easier to kind of keep things a little informal between us. But what is the latest version number of the AASM scoring manual? Is it 2.0, 2.1, 2.6, or version 3.0? 2.6? Nope, it is actually version 3.0 is the newest one. So they have just come out with this one in March of this year, and all of the standards that are contained within are expected to be implemented in accredited facilities by December of this year. So you got a couple more months here to kind of get these things in place. The manual itself is still available only online. They don't have the print version out yet, but I always like the print version for keeping things in there. All right, so first of all, reporting updates. Question for you. Which new respiratory event parameter is now recommended? A, time below 80% oxygen saturation. B, time below 88%. C, time below 90%, or D, time below any specified oxygen saturation at the discretion of the practitioner. D is correct. That is the right one. The others you could have already, but the time below any specified oxygen saturation threshold is there. And then also on the note here that the oxygen saturation threshold used is at the discretion of the clinician. Some of the others are important. The time below 88%, all your DME providers want that if you're going to put them on oxygen, and some other levels there. But that is the key one as far as oxygen goes. And so also on your reports, there are going to be some new requirements for reporting both the 3% AHI and the 4% AHI. And so if your equipment doesn't do that, you need to be talking with whoever makes your equipment in order to make sure that you can add that information to your reports. But reports will look something like this. Like I say, that you'll have your oxygen duration below 90, below 88 is common, and then any other level that the practitioner recommends or desires. All right, which new reporting parameter is now recommended for children? A, hypoventilation during the diagnostic study. B, hypoventilation during a PAP titration. C, the occurrence of snoring. Or D, the head position and associated with respiratory events. Ooh, it got quiet. Any ideas? B? D? D was actually already recommended for pediatric patients or for children. So particularly for infants. C, the occurrence of snoring. Can you believe that never before was the occurrence of snoring recommended by the Academy to report in pediatrics? So that has been added. For infants in particular, D was already there, that head position was recommended, that you note that in association with respiratory events. All right, so those are some of the new reporting parameters, and they're pretty simple. But now we've got some new technical and digital specifications as well that are on the new manual. First of all, you have to have the ability to display raw data for review, manual scoring, or editing of automated scoring. And so that is one of the recommended things. You have to be able to see on Note 16 that the raw tracings are viewable in detail with the ability to edit events. And this is regardless of which sleep system that you're using. And some sleep systems nowadays don't allow you to edit some of those. If you're using some of the new AI, you need to be able to edit what the AI says as far as the scoring. And so keeping up with those things, you really have to watch out. They also updated the high frequency filter setting for EKG to 100 hertz instead of the 70 that many people used. And they specified that recorded video data must be synchronized with the PSG data within 1 second. Evidently, there were some that varied by a little bit more. And so that was a couple of the changes that they made there on looking at the raw data signals. Another change here, what are the maximum levels of recommended impedance? We've got A for EEG, EOG, EMG, and EKG less than 5 kiloohms. B, we've got EEG and EOG less than 5 kiloohms. And then for C, we've got EEG and EOG is less than 5 kiloohms and EMG is less than 10. Or D, EEG and EOG less than 5 and EMG, EKG less than 10. Maybe I should have done the phone thing. That would have, everybody could have poked it in and been anonymous. Any guesses?
I would say A, because the EEG is supposed to be low anyway.
Yep. But the EEG and EOG are actually the only parameters that previously had a standard. The standard that has been added now is that the EMG has to be less than 10 kiloohms as well. And here's where the manual says that it applies to EEG, chin EMG, and EOG electrode impedance, that the maximum electrode impedances should be 5 kiloohms. And then they say that limb EMG of 10 or less are acceptable, but 5 or less are preferred. The AASM scoring manual currently does not specify maximum impedance for EKG. However, it is suggested that the impedance should be adjusted so that baseline amplitude of noise is minimized. So, a few different things there that were not there before, with adding on which inputs need to have what impedances and what they need to be. All right, another technical, actually this is just another example of it. So if you look at that, 9 kiloohms on your limbs is a good connection. This one on your EKG, 185 would be bad. They would recommend that being lower. And then also it's specified in a different place in the manual when it talks about periodic limb movements and shows the exact placement for the anterior tibialis muscle, that for measuring those you should not use 60 hertz notch filters, because it impacts an area that you're recording, and so you should avoid that. And then impedances need to be less than 10 kiloohms, but less than 5 is preferred, but might be difficult to obtain, specifically in that diabetic patient or that guy with the waxy legs that you have trouble prepping anything on anyway. So 2 different places where that is mentioned, first in the overall and then specifically in the PLM's monitoring. All right, questions so far? Nothing? Okay, we'll move on then. So sleep staging rule updates. There are a few there, and we'll jump right into those. So which of the following rules were updated in the sleep staging rules for adults? Is it A, that they updated the terminology for alpha rhythm, or B, that they added a typical frequency range seen across age groups? C, that they updated the amplitude criteria of qualifying slow waves? Or D, added tips for correctly identifying qualifying slow waves? So A is the answer, absolutely. They updated the terminology for alpha rhythm. Matter of fact, they did away with the terminology for alpha rhythm. Alpha rhythm is no longer called alpha. Alpha is called posterior dominant rhythm. So the posterior dominant rhythm, or alpha, over the occipital region for individuals who do generate posterior dominant rhythm or alpha rhythm with eye closure. So can't call it alpha anymore when they close their eyes. It's called posterior dominant rhythm. And they go on to explain that a little bit, because in other age groups, if you look at note number 6 there, posterior dominant rhythm has traditionally been called alpha rhythm. However, the term posterior dominant rhythm is preferred because not all alpha activity is posterior dominant rhythm. Alpha activity predominant in other brain areas, for example, in frontal and central derivations, and alpha sleep is not posterior dominant. And then the normal range for posterior dominant rhythm in adults is 8.5 to 13 hertz, so the same frequency range, but in an infant over 6 months and young children, it typically starts in the upper delta and theta frequency and then gradually increases in frequency as they age. So as they're younger, it might be slower than alpha, so it's called posterior dominant rhythm. And then as they age, it's going to speed up and look more like our adult wake alpha. So big change in terminology there, no more alpha, and always posterior dominant rhythm. So here's an example of it, and you can see it still looks like alpha to me, but you know, who am I to say? I've been around a few years, but now, a couple of other things were added. They have a note in here. Due to reported difficulty correctly identifying qualifying slow waves, 75 microvolt lines inserted in the recording or identification of delta waves by concurrent digital analysis may assist the score. So this again is something that they're asking of your software. And so you can see here on this line here that you have a baseline. And then they have set this at, 37.5 microvolts above and 37.5 microvolts below, so that you have a 75 microvolt slow wave altogether. And you can see that height. So being able to apply those thresholds can help you visualize it. And then also the ability to measure the actual wave and see, is it actually a delta wave, and look at each individual wave. This is something where they're starting to push this. So it'd make it a lot easier for training some new techs, wouldn't it? So particularly those visual lines. I really like that. So then they say that candidate slow waves might be marked such that the total duration of slow waves can be quantified. I think that would be really cool if your software not only measured these, but also showed you the total, so that you knew when you hit 30% of the epoch that you could, or 20% of the epoch, 6 seconds total. Sorry, when I get talking, my brain outruns my mouth. And so that would really be cool on there as well. But you can kind of add those up visually and know when you've hit stage 3. All right. Those are just pointers that I forgot to click. And we'll go on to arousal rule updates. Big change with arousal rules. And it's actually been around for a little while because it's never been specified in the manual, but now they're making it very clear how they want us to score particular arousals. So here, which arousal should be scored? A, B, C, or D? They're all really arousals, but there's one that's different from before. Well, I should say shows with more clarity. So answer here is C. Did it go? There we go. C. Because it's longer, and you notice that what happens? They're awake. So what would we have maybe scored this as previously? An awakening, right, versus an arousal. There has never been any definition of an awakening in the manual since 2007. It used to always be if it was less than 15 seconds of an arousal, we call it an arousal. If it's greater than 15 seconds, we call it an awakening. The manual has never defined that, but now has made it very clear in the wording of the arousal rules that you would score arousal if it immediately precedes a transition to wake. That is, both the arousal and transition to wake in your sleep staging change would be represented there. And so it's not an awakening, it's an arousal with a transition to wake. So small difference, but they're very specific. This is how we want this one to be scored. So no more awakenings, but an arousal that transitions to wake. Does it make sense? Y'all are so quiet. Good, good. So how about this one? Which arousal should be scored here? A, B, or C? Or none of them? Look again, we can't really see what happens before. And I'll give you a hint. From here to here is longer than 10 seconds. So C should be scored. Can you score an arousal from being awake in an awake epoch? Yes, you can. You have to have... Not according to your software, but your software needs to be according to the rules. So according to the rules, if you have at least 10 seconds, you can arouse. So if it's an awake epoch, where the majority of the epoch is wake, and it's scored as wake, but you have 10 seconds of sleep, and then an arousal, you can absolutely arouse from being awake. That one was a surprise to me. Yes, I would expect that many of these are going to show up on the new interscore reliabilities. So they're going to test you on these sometime after December when these take effect there again. So hard copy is supposed to be out by the first of the year as well. So I think it's pretty interesting that, it's always been in the arousal rule that you needed 10 seconds preceding the arousal, but it was never very clear in this sort of situation how they wanted you to score that. And so they're really working to clear up some of these things in this particular release of the manual. Yep, you can score the respiratory event as well. Yes, on an awake page. So are the companies improving their software? Yes, they are. Some of them don't. Some of them will let you start an event in awake epoch or end an event in an awake epoch, but scoring an event in an awake epoch, if it's 14 seconds, it's less than 50% of the epoch, so the epoch could still be wake, but you could have a 12-second respiratory event with an arousal on that wake epoch. And so those are going to be allowed and counted is the current status. Yep. And some of them allow, I know with our Knox software, you can allow events in wake, and there's just a checkbox that you put there, and many of the others may have that as well. All right, I knew that one would get a little bit of comment because it's different. It's quite different. Yep. Okay, cardiac rules update. There are some electrode placement updates here. Which is the new optional EKG placement? A, B, C, or D? Nope. A is what? Lead 2, it's the recommended now. B is backwards from that. It's actually C. So lead 1 placement is now an optional EKG placement. So you can put it shoulder to shoulder, like many people just did anyway. There were so many people that didn't do lead 2, they just put it shoulder to shoulder. Well, now you're okay, actually. So relief there for your accreditation. You don't have to make sure you remember to do it different when the accreditation committee comes and looks at you. So, all right, but using a single modified EKG lead on the torso with the electrode placement shown in figure 2 If an artifact-free signal cannot be obtained using the modified lead 1, then a modified lead 2 must be placed. So if you have trouble with it there, then you can do that. I actually did a training out at Kaiser Permanente in Fontana, California not too long ago, and they routinely put them here, so on the back. And so Dr. Huang out there is always on this disruptors program and talking about different ideas in the technology, but that really keeps things out of the way because they do a lot of portable testing out there. So really interesting. I'd never run into that one before on the back, lead 1. So it's still qualifies as lead 1, but it's on the back instead of on the front. You can get a lot more muscle interference. Yes, you can. All right, and so another note that they put on there, lead 1 is typically derived from electrodes placed on the right arm and left arm, but the negative electrode can be placed below the right clavicle at the midclavicular line and the positive electrode below the left clavicle. So you don't want to get up too high. You want to be below the clavicle here when you're placing this in particular. One more thing here on that they say you can place additional leads if clinically indicated at the discretion of the practitioner. So your doc can tell you, here's how I want you to do it, and you can do that without any issue. And observing the EKG using a 10 or 15 second page might improve detection of arrhythmias. So if your software allows you to have multiple sheets, like I know many of them do in your workspaces, you can have a little box or a sheet that's at a 10 or 15 second so that you can visualize the EKG a little bit better. Lead 3 is typically derived from electrodes on the right arm and left leg, but the negative electrode can be placed below the right clavicle at the midclavicular line and the positive electrode on the left lower chest at the anterior auxiliary line, the 6th or 7th intercostal space. So most of those things are the same. Now there were some other changes on arrhythmias. So they have added some to the list. Remember, we were just doing narrow complex and wide complex basically, but they've added to those as well. So now you can report first degree AV heart block, second degree type 2, and also third degree. And the last one that they added is a right ventricular pacemaker rhythm that they believe that you can derive from each of those electrodes. And so note 1, reporting of these should only occur if the quality of the signal is sufficient for adequate identification. I know on all of the different talk sites, people are going to say, you can't identify those from a 2-lead EKG, but we'll just sit and watch that argument on Facebook and enjoy the discussion, as many of us do. But these ectopic beats should be reported sustained by Gemini or trigemini, frequent premature atrial or ventricular contractions, and use of a single EKG lead is unreliable for detecting any ST segments. And so I do see some people that do that. They just use a single lead and then reference it somewhere else on the body just to try and eliminate having to put other leads on. They make some notes on sinus rates and their different values, and then also bradycardia defined by more than 30 seconds of a stable rhythm. So sustained sinus bradycardia has to be at least 30 seconds in order to identify that. And then also increasing the high frequency filter will aid in detecting the atrial or ventricular pacing spikes. And so that was the reason for the previous recommendation of increasing the high frequency filter, as I mentioned. Okay, now we've got some limb movement rules updates. So these are kind of interesting that the following define something called a candidate leg movement. I thought that terminology was interesting. So from the time you have your first movement, it's a candidate for being a periodic limb movement. And so identifying those, the duration hasn't changed. It's still 1/2 to 10 seconds. The minimum amplitude increase has not changed. It's at least 8 microvolts over baseline. The offset, when it returns to the 2 microvolt, I think it is, over the resting level, yeah, under D. It ends after 2 microvolts return, and then E, I'm sorry, it looks like a C right up here with my bad bifocals, that a portion of or the entire limb movement has to occur in an epoch scored as sleep. So on this one, they're very specific, that while you can have an arousal after 10 seconds in awake epoch, you can't do the same thing with a limb movement. It has to be in an epoch scored as sleep, or a portion of it has to be in an epoch scored as sleep. And so if we look at these here, we've got A, B, C, D, E, F. Which ones should be scored as limb movements? All of them? Almost? A, B, D, and E? So really we're looking at the A, B, D, and E. Why? Because these follow respiratory events.
But if they're not occurring within a half a second of the end of the respiratory event, they're occurring during the middle of the respiratory event, that can be scored?
Yes, it can in the middle of the
So, but if it's within a half second
of the end, right? And it's either preceding or succeeding the end, so it can be a little bit on either side of it there. And so no change here really, and you still have to have your events that fall into that period, and you can score the arousals based on those events, and then if they're after a respiratory event, then you do not score them. And that's just another close-up there on the limb movement scoring that I wanted to say again, that you would only score one limb movement candidate if they are overlapped. So you don't score them both out of the same. So no rule change there, but there's just some clarifications there in the rules. Okay, and then respiratory rules update. These really aren't so much changes, but some of the terminology around them has changed. So which statement here would define the recommended hypopnea rule? A is a 30% drop of nasal pressure for at least 10 seconds with at least a 3% desaturation or an arousal. And B, a 30% drop for at least 10 seconds with a 4% desaturation. C, a 50% drop of nasal pressure for greater than 10 seconds with at least 3% desaturation or an arousal. And then a 50% drop of nasal pressure for greater than 10 seconds with a 4% desaturation. Which one would be the AASM recommended hypopnea rule or rules? Not anymore. A is the answer. It is the recommended rule. They have downgraded. Click, come on. I'm not advancing here. I don't know why. There we go. So it's only A. As far as the hypopnea rules go, they have said that this is the rule. There's no more 1A and 1B recommended, but there is a 1A and 1B optional now. So the wording around the Medicare definition for hypopnea has been changed from recommended to only optional. And so they're kind of going, at least in their rule. We all know we still have to do it because Medicare is not going to take that 3% rule. But the wording of it has changed a little bit in the manual. And so it's a 30% of pre-event baseline using your nasal pressure on a diagnostic study or your PAP device flow for a titration study, or an alternative hypopnea sensor, which can be RIP belts or something like that. And the duration has to be 10 seconds, and there's a greater than 4%. So that is an optional rule now for 1B, no longer a recommended rule. And there's also this respiratory event. What do you think you would call this respiratory event? Obstructive or central? So, there's a clarification from the AASM on situations like this. Does everyone know what this bottom line is? So your patient PAP pressure, they're on BiPAP ST. These are machine delivered. And so the idea is this real or is it machine delivered? It's machine delivered. So if you have a backup rate set on your BiPAP ST, then they say these are special circumstances. So when you're scoring respiratory events during a PAP titration using a backup rate, score a respiratory event occurring during PAP device-triggered breaths as central if all of the following criteria are met. There's a decrease in the PAP flow signal, the device-triggered pressure pulses occur during the event, and there's no evidence of spontaneous or patient-triggered respiratory effort during the event. So for these, we're going to score them as central and believe that these bumps in the effort are artifact from the delivery of the backup breath. So I loved that they added this. We never had any direction like this on PAP studies before. And so this particular piece is quite valuable, I think, in looking at data. And so things like this, that your central apnea index derived on a HSAT might differ from an equivalent parameter derived during a PSG due to the use of movement time or monitoring time rather than total sleep time, and reduced quality of respiratory effort signals during unattended studies. So if you're doing an HST, this comment should be inserted in your report if you're even reporting central events, which some do and some don't on HSTs. So we need to make sure that we add that. All right, so how about this one? Is this a respiratory event? Yes? What kind? Do you score those? Yes, you do. You used to not, but according to the AASM, the question is it 10 seconds long? Yes. What kind of apnea is it? Period. That's it. So that has been clarified also in this new rule. And I don't know why that's blank because that had my explanation on it. Okay. So post-arousal central apnea. Let me see if I've got, there we go. So post-arousal central apnea is to be scored if it's 10 seconds long. It is up to your physician to decide if it's clinically significant or not. As far as the tech goes for the rules, we score the rules. So if your physician in your lab tells you don't score them, I don't think they're clinically significant, then you know what you ought to do. Don't score them. He doesn't think they're clinically significant. Your practitioner has the rules that he can manipulate there and says, I don't think they're clinically significant. But if you're taking an exam or if you're taking an interscore reliability, score the rule. If it's 10 seconds long, what kind of apnea is it? It doesn't matter if it's post-arousal or not. They are now to be scored. Right, yeah. You can't look at one page. You've got to really see the pattern. You're absolutely correct there. So how about this one? Is it a post-arousal central apnea? Back here. So we've got some sleep here. We've got, what do we got here? Posterior dominant, not alpha. Posterior dominant rhythm for the majority of this epic. We've got some nice slow rolling eyes so that we're like, okay, well that could, so they can be deceptive still, but if the epic is wake, we cannot score any of the events if the epic is wake there. So, something happened when they converted. There it is finally. Okay. So very specifically it says, does the AASM manual differentiate centrals that are post-arousal from those that are not preceded by an arousal? And their response is very clearly the AASM scoring manual does not differentiate post-arousal central events from other central events. If the events meet scoring criteria, they should be scored. And so we finally have an absolutely clear answer for should they be scored or should they be not scored from the AASM. They put it in there as plainly as they could. Can respiratory events immediately following an arousal be scored? They said yes. Respiratory events that otherwise meet criteria for an apnea or hypopnea or RERA can be scored even if they follow an arousal. And then they also put a note in here that says if the apnea or hypopnea event begins or ends during an epoch that is scored as sleep, then the corresponding respiratory event can be scored and included in the computation of the apnea-hypopnea index. This usually occurs when they have a high AHI, with events occurring so frequently that sleep is severely disrupted. And epochs may end up being scored as wake because less than 15 seconds of sleep present during the epoch containing the portion of the respiratory event. However, if they occur entirely during an epoch scored as wake, then it should not be scored or counted toward the AHI. So I'm sorry, I said that wrong with the 10-second thing earlier, didn't I? They should not be counted if they are entirely. So if they overlap at all, we can score them, but if they are entirely in a wake event, then we cannot score them. I apologize for saying that incorrectly earlier. All right, so here, is this a respiratory event? I've scored them as one, hadn't I? Or can we score it as one long hypopnea because of the DSAT? Mm-hmm. So I'm going to blow it up here and add some more lines to the whole thing. Keywords are pre-event baseline. Look at our pre-event baseline. These are some sort of other breaths. You can't see a lot of the other, but here's our pre-event baseline if we're drawing it. Have we met the criteria for the decrease? On this event, I would say yes. On this event, absolutely not. I don't really think that we've dropped enough. So, and we also have a 1% resaturation in the middle of our oximetry. So when you blow it up here, you can really see the difference there a little bit. So I'd probably call this one. But again, those same graph lines that they've asked for looking at delta can be extremely useful when you're scoring respiratory as well, to help you visualize that 30% drop and be able to score that event better. So. No, I didn't have anything. Yep. And so here's the rule. Score a respiratory event as hypopnea if all of the following criteria are met. The peak signal excursion drops by greater than 30% of pre-event baseline using nasal pressure, PAP device flow, or an alternative hypopnea sensor. The duration has to be at least 10 seconds, and there's at least a 3% desaturation, or it's related to an arousal. So for scoring an apnea, hypopnea, or respiratory effort-related arousal, the event duration is measured from the nadir, or the low spot, preceding the first breath that is clearly reduced, to the beginning of the first breath that approximates baseline breathing amplitude. So we're always going from this low spot. When they first came out with this rule, I had to look up what a nadir was, because, I mean, I'd lived in South Alabama, and if you said nadir, then that meant hit the ditch, you know, because bad stuff's coming. But the nadir just means the low spot, you know. It just means the low spot. So you're measuring this low spot before the first breath that is clearly reduced to the low spot before the next breath that approximates baseline breathing again. And so by looking at the events from there, that's how you're going to be sure that you have your correct. So if that baseline breathing cannot be easily determined, and when an underlying breathing variability is large, like there was in this sample that I was showing you, events can also be terminated when either there's a clear and sustained increase in breathing amplitude, or if a desaturation has occurred, there has to be an event-associated resaturation of at least 2% in that case. And so the 1% resat might not, it would make us question the event, but we couldn't definitely end the event without other information based on that. All right, and so, I'm doing good. That's a first. So again, does the question and answer section online, does the AASM scoring manual specify how the pre-event arterial oxygen saturation is defined? This is needed to determine the amount of desaturation or fall from baseline. And their response says the AASM scoring manual does not specify exactly how the pre-event arterial oxygen saturation is defined. There is insufficient data or consensus to make a specific recommendation for what to use for baseline breathing when a patient has repetitive events. So what they're saying here is you got to be careful with this. If you're looking at your pre-event baseline, I would go from here and look at what was related probably to that particular event. Other people would say, well, my baseline was all here, 92, 91, and that this was actually a resaturation, and so I really can't count any of these. There's variation there. Talk to your physician, find out how your physician wants you to score it in your lab, because here the AASM said, we don't think we have enough information to tell you exactly what it should be in that case.
Some of those physicians have actually said you could use a pre-event baseline as whatever your baseline was at the start of the study, and then if it drops,
If you dropped, right.
that you can use that.
So if you put them to bed and they're laying there awake during biocals and their SAT was 98, and then they went to sleep and it dropped to 92, well, you've got a 4% DSAT all night long. And so you could score all of those. And so there's still an ongoing discussion around those sorts of things. Usually, as they say, pre-event baseline, then I'm looking for what that pre-event value was, because it's always going to be changing, as we know, with ours. So still some question there, and they didn't take a firm stance here, even though we might have wished that they would have. All right, so thank you very much. These, again, AASM accredited facilities are recommended, and you know when the AASM says recommended, what's it really mean? You got to do it. That they're recommended to institute these revised rules by December 2023. So if you are not aware that there's a new manual, you need to get that new manual. The things that you will be blatantly obvious on an accreditation are the reporting pieces. That you've got to get your reports fixed quickly and make sure that your vendors can support that, the 3 and 4%. I know we've been asked for it a million times already, and we have a workaround for it and a software release coming for ours, and I'm sure that all of the other vendors out there are doing exactly the same thing. I know InsoData, if anybody uses them, they got a big ad that they put out in Sleep Review maybe a week ago that showed their 3 and 4% reports, and they look really good. So everybody's working on that to help you out and make sure that you meet these guidelines as well. So new guidelines starting in December on the new rules. And thank you all again for having me here again, and I enjoyed giving the talk. Questions?
Thank you, Byron. Any questions? Okay.
Very technical.
And then they don't have the same type of rules with
Right. Yeah, the home sleep apnea testing are a whole different ballpark and much more relaxed.
I mean, it's like most of the systems on the market don't even have, they either have no belts, they have one belt, or they have two belts. So just when they get that technical about a hypopnea in an event, and then the other thing I was going to say is I'm one of the people that argues about the two-channel EKGs. So one thing that I always tell people is you can have those arguments all the time, but please just make sure your patient is asymptomatic before you get on Facebook to try to figure out what's wrong with the EKG and the
Oh, absolutely. And for those online, he's talking about the EKG requirements, making sure that you have a good one. I don't know if everyone heard about this. Was actually up in the Northeast that a sleep lab was doing a car seat test on an infant going home. I guess they got involved in that somehow. And this is something that gets me going on lab managers. If you have problems with your equipment, it's time to get new equipment, because the techs who are working here immediately questioned their equipment when they had no heart rate. And they wasted valuable time checking their equipment when they had no heart rate. And a baby died because they were checking their equipment looking for a heart rate. And it's absolutely unbelievable, in that case. So if we have that sort of conditioning in a lab that when something happens, our first impulse is that, I've got to check my equipment. No, you check your patient, you check your patient, you check your patient. And I will not get off of that soapbox ever. That's the first thing you always do, is check your patient no matter what. This was an unusual situation, not a regular sleep study. It was a baby seat test, but even more so. You're sitting there. Yes.
So unless there's symptomatic, that's when you get concerned. Always check patients.
Yep. But it throws me right back. If the condition of your equipment is such that you are conditioned to look for problems versus evaluate your patient, you've got something big going on in your lab, and you need to get that fixed. It just makes me angry. But, that's for sure. Treat the patient, not the equipment. So.
All right. Thank you again.
Thank you, guys.
We appreciate it.